All right, so welcome to the class, and today we're going to into the history. But I just wanted to show you this video. We were able to start this course sometime a couple weeks back in Nigeria. We're in Lagos, Abuja, Port Harcourt, Ibadan, Warri. And we want, so my goal, I'll keep saying this in every webinar. My goal is to be able to send this information across. This is a gift to the whole of Africa. I just say, what can I do to improve our skills? What can I do to give back? What can I do to just improve the quality of care that we provide? And I found a way to do it. The things I've learned, it has cost me a lot of money and time and sacrifice to learn the things I've learned, but I believe I can share, and someday, obviously, you are going to be out there taking care of people, and that's the most important thing. So whatever you gain is going to be of economic value to you, but also we are able to serve our continent. So today we're going to talk about dental implants, the past. We want to go back to the past. So what happened in 1952? It's 52 till today. We're catching up. We're going to get caught up, and we're going to improve on what has been done in the past. For implants, the thought of it started way back, and we're going to just go through. I've used an article by Thomas Albrechtsen. Today, you want to learn about some people. So today, this is the basics of implants. I know most people said implants started way back in the Mayan time. You go back to the Egyptian mummies, but I'm not going into all that. What people did to replace teeth way back. I'm going to go back to 1952, where a physician, not a dentist, began to think about a way by which we can get to replace. And that is our course for today. So I've attached this article. Is inside the classroom, so you can have access to it. So I'm going to be talking out of this. This is like a beautiful summary for me by Thomas Albrechtsen. These are some names you have to know when it comes to implants. So like I said before, one person in this class that proves to be an excellent communicator, an excellent team member, an excellent class member, and distinguished person is going to go, and you're going to meet Thomas Albrechtsen. That is our gift to the one person in this class at the end of this class, in terms of grades, in terms of attendance, in terms of just doing your work. You're going to meet Thomas Albrechtsen in Sweden. We are going to sponsor your trip, because Sweden was where dental implantology started, and so it's still a mecca for oral implantology for around the world. People go there to see what was done. So the article is titled "The Impact of Oral Implants, Past and the Future." So it dates back to 1966, and it made a futuristic, very powerful article, I would say, to 2042. What's going to happen in 2042? We are how many years behind, but we are right here, in 50 years later, we are right here, almost 50 years past when it started, we are right here in 2022. And some of us are just getting introduced to this concept, but it promises. So read there's nothing due. I'm not going to put anything due for this. This is your general knowledge, so you can get some time to relax. But there's going to be something for you to do on the osseointegration portion by Dr. Aladelusi. So this were the first implants that were placed. It looks like a blade, and the blade was hit into bone, and the one on the right hand side, it was I'll show you the type, subperiosteal, and it was resting on bone underneath the periosteums. It was sewed in there, and so they've tried several things in the past. Today we are more into endosseous implants. So once everybody has to know this name, Per Ingvar Brånemark. Brånemark was placed his first implant. He started looking at osseointegration in 1952 and placed his first clinical oral implant in 1965. 5 years, his results were considered unacceptable with a success rate of 50%. He did not give up. This guy was not a dentist, but he was a physician, and he said, you know what, this is possible, and we should use it. We should use osseointegration. They were using it for hips, for other parts of the body, but in the mouth, he was the one that started this beautiful thing. And also, so we are meeting also, like I told you, this lecture is going to be about some people. So I want you to put your picture somewhere at the end of this lecture. What are you going to contribute, or what will be your part in oral implantology in Nigeria, sub-Saharan Africa? When you're talking about oral implantology, they go to South Africa. There's nothing in Kenya is beginning to be there, but I know Nigeria has the potential of owning this, and that is my goal. That we're going to take. I'm hoping to have one conference soon in Nigeria for oral implantology sometime in October during the NDA conference. I'm hoping, that is my dream, that we can bring some of those people into that conference so that we can have our own Nigerians, West African, sub-Saharan Africa interaction. So Thomas was he's also a physician who focused his PhD thesis on the healing of bone grafts, and he was a close co-worker of Brandemack, Ingvar Brandemack, in the developing of osseointegrated oral and craniofacial treatment. With they got a breakthrough internationally in 1982. I don't know where you were then, and in 1992. These folks have been working really hard. So like I said, he belonged to the original osseointegration team from the University of Gothenburg. So that is where, if you are the first person, if you're the person that we pick up in this class, you're going to go to Gothenburg in Sweden, and you're going to meet this gentleman. He's still there, he's retired, but we'll organize for you to move around that place. And he's currently Professor Emeritus of Gothenburg University. Brandemack said no one should die sitting with their teeth. No one should die with a denture, essentially. He felt that tooth loss was a disability, and that, I mean, if you have implants, then why should you not have one? He was asking, give me a reason why you want to go with toothless. He was like, we can put some teeth for you. And he was so sure of the fact that that was possible, that he said no one should die with their teeth sitting in a glass of water, which is your denture. So he said, you know what, you can have teeth that will last you a lifetime. And he passed on in 2014. Great man. But when he started, his work was not accepted. I'm going to, your hand is raised. I would pause. I don't want to just move on. If you have a question, so let me see whose hand is raised. Do you have a question? Miss Dr. Essien, do you have a question? Dr. Essien, you are able to speak if you want to. Student Dr. Alma, I need you. I have some work for you. I need you to look at the chat section. If there's something urgent I will need to attend to, let me know, and I will attend to it. So if you're, who else, if your hands are raised, let me know. And if it's by mistake, I will lower the hands right now. So anytime a hand is raised, calls my attention to do something about it. Okay. So Alma, please take a look at the chat section, and we would continue from there. So look at it just in case there's a question. But I see most people on there. Okay, so he was faced with non-acceptance. It was regarded as impossible. Osseointegration was considered impossible by many. People said there's no way a foreign object could ever be anchored in the bone. So when it came, Dr. Brandemack faced a lot of opposition from Swedish Dental Society, from physicians from everywhere, that you cannot do this. But he pressed on, and there's this another name you ought to know. His name is George Zab. George Zab led the first international team. So this guy is based in Canada, Toronto, Canada. And he went over. He's like, you know what, something is happening in Sweden, and he led a team of people to go and study what Dr. Brandemack had already started. They arrived in Sweden in the late 70s. I'm going to ask, where were you then? To be trained in the Mack method of implant placement. And this inspired a Toronto replica study of oral implants in 1979. So George Zab is a man you ought to know. So we have three names already. Three names. We have Thomas Albrechtsen, Ingvar Brånemark, and we also have George Zab. George Zab, did tremendous work. So the first patient also, there were other clinical applications. So it wasn't just the tooth. The first patient that had a missing external ear was treated in 1977. So they used a bone-anchored hearing aid. So the hearing aid was osseointegrated and through the skin, and the person began to hear again. So they've already used that, other clinical applications in the. And one of the things that brought acceptance, the final acceptance, was taken in 1985 when they published the publication of a tissue-integrated prosthesis, Osseointegration in clinical dentistry. This was published in 1985. We're going to go up to the history. So, people were wondering, is this thing going to last? Is it for real? After the first ones that they had placed failed, they came up and the world began to accept what was happening. I want you to know two most important days in your life. I throw this in: the day you were born and the day you found out why. Brånemark felt it was his purpose on earth to disseminate the fact that bone can be integrated with metal. And that was why he lived for. Quick question here. I don't know, have you found why you were born? Have you found out? Have you found out why you are here? For me, I think my work is to be able to send this information to every student in sub-Saharan Africa. That is my current purpose on the earth. And that's why I'm thankful you're part of it. And I need your help in sending this information to every dental student in Africa. That is my goal. That's what I woke up this morning. I want to be able to send this information, what people have already researched and done. And have you found out your purpose in life? Just a rhetorical question here. George Zab found he took that as his responsibility to recognize. He was the first international professor. Other people from around the world were just looking skeptically at what Brånemark was doing in Sweden. Dr. George Zab from Toronto said, you know what, this is my purpose on earth. And he said, you know what, I'm going to, he went to Sweden, they studied it, they found it to be true. They did some clinical studies, and he's principally responsible, George Zab, principally responsible for spreading the message about this revolutionary treatment. For me, I call him a crusader. Crusader usually is associated with faith, but this one, he was a crusader for oral implant, and it's still going on. There are centers in Toronto today who still talk about, and it's still there. It's no longer actively, but kind of retired, but it still gives a lot of talks to various people. So if you want to, if you have an opportunity to go to Toronto, Canada, there's a Toronto Institute for Implantology. Will be a good place for you to visit. So there was this long-term Toronto study, because in anything that's going to be accepted by the scientific community, you need to have a basis for it. People are not going to go with, a case study, I did one thing on one person. No. They're going to do clinical study that involves follow-up prospective studies where they can go back and these long-term studies verified the possibilities of oral osseointegrated implants. And that study became one of the world's most important implant data banks till today. So that was a study. You want to have a copy of it? I have a copy of it. I'm going to post it in the group later tonight so that you can download it and have it in your hand. This was from the George Zab and Smith at the University of Toronto Faculty of Dentistry back in the day. So the Toronto conference. George Zab held a conference while the world was still skeptical about it. He invited representatives of all major dental schools in North America to a conference on osseointegration in 1982. This is 2022, many years later, and 70% of the invited schools decided to participate. So in October of this year, I want to do a little part of this. Osseointegration is already accepted. People are placing implants around the world, but I don't know if our schools have accepted it like that. Schools in Nigeria. I don't know if schools in Africa, because there are constraints, financial constraints, and one of the other constraints is the training. Most of the people who are supposed to teach it are not as trained in it. So we are going to offer, I'm going to have a NDA conference. I'm going to put together a program where we're going to invite all the deans and the restorative faculty and surgical faculty of all Nigeria's dental schools to a conference of oral implantology in October of 2022. I'm like, George Zab has inspired me. He did this in 1982, and for Nigeria, it's already accepted, but we're going to find a way of getting laboratory components in all schools. My goal is to be able to put laboratory components in every dental school in Nigeria and in Africa. That is the goal. It's huge, and and by the grace of God, it's going to come to pass. Like I said, once you're doing anything clinical, you need to have a strength of evidence. So this is the strength. If it's a case study is at the bottom of the chain. If it's a cross-sectional study, if it's a case control study, if it's a cohort study, if it's a randomized control trial, if it's a systematic review, if you have a systematic review, that means that is the top in the hierarchy. I don't know how many systematic reviews about implants. Do we have any randomized control trials of implant placement or review in Nigeria? I don't know. Do we have any cohort studies? Do we have any case control studies? I don't know how many studies are out there. Does anybody have anything to say about that? Would you be interested? So I'm trying to put a research team together. Is anybody interested? Send a message to me via training@hhands.org. I'm trying to build a team. If you are interested in part of being a study, please let me know. We want to look at what has been done so far about oral implantology in Nigeria. I want to contribute to our quota so that Africa becomes a place people can look at as a major market. All right. They also found out that in the elderly, so George Zab, so we just left 1982. So it came to 1990s. George Zab and Dr. Smith did find out that being elderly is not a contraindication. Most of the patients I have right now are elderly. I have like 80-year-olds, 89-year-old, 90-year-old patients, 70. They want to place implants. I think they heard from George Zab. You don't have to die with the space in your mouth. You can put my patients are like 80-year-old, 82, and there's no problem. And this is because somebody did some research. George Zab in 1990 said, you know what? We found out this. You can being old is not a contraindication. Today, Dr. Aladelusi will be talking about osseointegration, but it's been defined here as a process whereby clinically asymptomatic rigid fixation of an alloplastic material is achieved and it's maintained during functional loading. It means that you place a metal, this is an implant, inside bone, and there's no symptoms, there's no pain, there's no bleeding on probing, there's no exudates, there's no bone loss, and the implant you place in bone is maintained, so it survives. It survives in a bone during function, and you can use it to do just your chew without any symptoms. There's no pain. So once you can achieve that, they said it is called osseointegration. It is being used in the knee, in the hip, in your arms, in other parts of orthopedics. They use this technology. And also it has been proven, so many studies that say it is successful And that is what it is. That bone survives, is married to titanium. Just, that is osseointegration. There's so much to it, and Dr. Tim is going to do give us a little expose. So there are different types of dental implant. There's subperiosteal, but back in the day, there's transosteal implants and there's endoceous implants. So a subperiosteal implant was any implant that receives its primary bone support by means of resting on bone. So this was resting. So it goes underneath the gums and it's resting. So they flap it and they rest it on bone. They kind of secure it there. That's what they had back in the day. Today, this is what you want to learn. I want to be able to do this. Endoceous implant, a device that is placed into the alveolar bone or the basal bone of the mandible and or the maxilla by transecting only the cortical bone. So this is what you are going to do at the end of today, and you should be able to give me an X-ray that looks like something like this without bone loss over time. Over time, there was once transosseous implants where it penetrates both, and it was more of plates or however they did it that passes through the full thickness of the bone. This is not being used very much today. So to today, implants have, this is 2000, we just talked about 1990, went to 82, 85, 1990, and this is today. This was a patient I saw a couple of days ago, and oral implants are now accepted after it was proved that they can function in the mouth without any symptoms. And we are looking at aesthetics and trying to simplify their use. I want you to be able to place, so this is a zirconium abutment, because in the front sometimes you want to use something that does not have that gray metal in it so that you can, it doesn't show through. And over this, you place your crown and you're good to go. This is today. This is where we are, and this is what you are going to be doing. And at the end of this course, you should be able to learn how to do this successfully. Previously, according to the article, it says that most implants were either minimally rough or very rough. Today, it is moderately roughened, such that, and it has been proven, sandblasted implants help. The osseointegration is faster because of all the surface materials that are being impregnated here. I see some hands up. If you have any questions, just type it in the chat and I will get back to it. Today, things have changed today. Back in the day, because today is about making money, you know. So most of the companies that make it, they start clinical testing after they launch the product, you know, which is not ethical at all. So these days, a product comes out after it has been documented. They've done their studies for 1 to 3 years before you can get an FDA approval. You needed to have tested it before. So the industry is being regulated such that they don't just bring out a product and just start testing it immediately, even before they do their clinical trials. So clinical trials, this is today, okay? Today, the companies, there are so many companies in this business right now. And Dr. Abraxan said that tomorrow, it looks into the future. Now, in the next 20 years, traditional bone graft will be replaced with self-made bone tissue, both based on the principles of in vivo tissue engineering. So most of us have not even gotten to use bone graft, but they're telling us in the next 20 years it's going to be done away with. That's his prediction. Anyway, but we're going to catch up with what was done in the past so that we can move along with what tissue engineering is going to bring forth. He said back when he wrote this article that there were going to be new ceramic implants. So you also have, instead of titanium, ceramic implants are here already. And he said there's going to be new ceramic materials that will allow the manufacture of implants as well as crowns that look more aesthetic, that look more appealing to the eyes. These ones are already here. So Thomas Abraxan it's a kind of a prophet, you know, because, you know, they've been there since 1952. And this is what it calls, this is one of the last things he said, the future of dental implants, that there's going to be new improved diagnostic tools. That is what we're going to learn in this course. The predictions that he made is coming to pass, because planning new treatment planning will become possible, which is going on right now. So we are coming in, if implants dentistry, this is your first introduction to it, you're coming in at an interesting time where it has evolved over time. The mistakes of the past have been corrected, and we are in a time where even the knowledge of human genetics will make it possible. That we are thinking that in the next couple of years, I'm sure we should be talking to Dr. Butali Aziz, where he is with his with his research, where you can produce new teeth, through in ectodermal, mesodermal structures in the body. They are looking for, and he says when that happens, there will be no need for dental implants. I mean, it's quite profound what he has said here, that these implants that you're trying to study, to come to his end point, that when science is able to produce new teeth, there will be no need for you to place an implant, which is, I don't know. It's very hard to take. We're still trying to get what an implant is, and it's telling us there's an end point to the use of implants. Very, very, I need to look at those articles. If you have, for extra points, you can do a short video. If you want to get some extra points, you can do a 3 or 5 minutes video about the past and the future. There are other resources you can use. There are other lectures. There are other articles in the group there. I will take from anyone just extra points. Just do a little more study on using the materials you have in the classroom, and you can get some extra points on dental implants. So we've essentially just gone through dental implants, and they've passed. It started back in 1952, and today we are talking about ways to treatment plan for it, because osseointegration is here to stay. I want to jump into this before quickly, so that you know what you're getting into. You're getting into a multi-million, billion-dollar business. The dental implant market is expected to grow at an annual rate of 11%. I don't know where it is right now, how many people the uptake. We have 4,000 dentists in Nigeria, and I want every one of them to be aware of this opportunity so you can learn. So those who are selling the products, we are trying to create this class. I want you to inform those who are selling the product. We are not here to compete with anyone. We are trying to make people aware so that they can buy the things and use it for our people and to increase their income. In 2000, from 20, is going to rise to an 8. Right now, it's about a $3.4 billion market, 3.4 billion, and it's going to rise in the next couple of years to 8 billion. So this is serious work. Like I said, this is old data that was available out there. 4.3. So it was 3.6 in 2020. It rose to 4.3, and in 2028, in the next 7 years, it's going to double. So this is a good time for you to get involved. This is a good time for you to get involved. A typical patient here in the United States costs about $4,000 or $5,000 for one implant. And I know in Nigeria it's about 500. It's still okay. We're hoping we'll be able to bring in some new products. I have a product I'm trying to introduce to make it accessible. I want you to be able to have an implant. So we have some free implants to give to folks. If you have a kit and more, to reach out to us and we can get the implants to you. Try it and see. I want every dental student to see what an implant is. So I want to come to your school, so talk to your deans. We want to come to your school so that we can have you do a lab exercise. That is my goal. So the key players today, are Straumann. Straumann is a key player. You have Zimmer, you have Nobel, you have BioHorizons. I know in Nigeria we have Bicon. Bicon is on this list. You have Megagen. I know there's Uvoh being sold by Straumann and Neodent, and several other products out there. If you have any products that you are aware of that is not on this list, could you please type it in the chat section? Any implant you have used, if it's not Bicon, if it's not Straumann, if it's not Ostium, what do we have? I want to know from the folks in this class, what implant system. There's Uvoh I'm aware of. There's Neodent I'm aware of. There's Bicon that most people, Dr. Karoui introduced Bicon, and it's still going very strong. But there are several implants. These are the top players in implantology. I'm hoping, I'm talking to Zimmer, so somebody to pray with me that we can get Zimmer into Nigeria and into sub-Saharan Africa. They can actually help with education. So I'm speaking with the educational leaders right now. So if you have any other product that is not available on the list, I want somebody to help me. If you are there, compile the list and send it to me later. Any list of implants being used in Nigeria or other parts of Africa, in Kenya, in Zimbabwe, in Rwanda, let me know so that we can reach out to them, because there's no point reinventing the wheel. If they already have their footprints in Africa, Nigeria has 36 states. There's a market right there. One of the factors driving the use of implants is increasing application. One of the drivers in Nigeria is going to be this course. This course you're taking is going to put implants and implant tools in your hand. So we are going to contribute to that through training. Because if you're not trained, you're not going to apply it. If you're not trained, your patients are not going to demand it. If you don't let them know that it's possible, they will never know. Most people will travel abroad. People go to India. People go to Egypt. People travel out of Nigeria to go place an implant for themselves. But if you have this skill, people are going to come to you. So we're trying to find a center of excellence where we can bring in other products. There's going to be an implant institute in Nigeria very soon. And watch out for it, so that we don't have to. So if you want to get trained, you just go there. The tools are going to be there. There's going to be everything modern in that place, and it's coming to pass. So this course is contributing to it, and that is my wrap up for today. Look at those articles. Like I said, if you want to get some extra points, go through the articles that I put there. I have textbooks there. Many people have talked about it. Do a presentation, any style you want, a video, PowerPoint, of a pictorial of where you think, or just a framework, anything you can do to just get some extra points. Talk about the future of implants or implants in Nigeria, whatever you want to write about that brings about the past and the future. All right. I'm going to look at if there's any question. Megagen, okay, yeah. I mentioned Megagen. Megagen is being introduced. Was introduced. Yeah, you have Megagen by okay. You have Megagen. So the Megagen is the only one among the three. Okay, which one is best for the patient? Right now we have endoceous implants. So that is what it has developed. Okay, Dr. Eugene. So that is the one. Yeah, that is the one that's being used today. That is the one that we are going to be using. So I have some implants already from MSDI implants. We're trying to introduce their folks in Nigeria. I'm trying to make it affordable. I want you to be able to own. I want everybody in this class to get an implant. If you want one, let me know. It's going to be at a ridiculous price. I need you to get an implant and a kit so that you can place the implants. It's not a mystery. Don't let anybody let you think that placing implant is mysterious. There's nothing. You just have to follow the principles, and we are going to get started. If you have a question, let me see. Among the three implants, please, yes, so how does how the implant surface treated to improve osseointegration? So there's a sandblasted one that is being put forth by Straumann. Straumann has an SLA. I'm going to pull it up so that you can see what I'm talking about. So they have improved they've improved the surface such that osseointegration is shortened and is less prone to peri-implantitis, and it lasts longer. So those SLA implants are actually, by Straumann, it's a groundbreaking technology that they've introduced, so you don't have to wait for that long. You can especially, so they have put that forth. Okay, any question here? Right. I believe that this is it. So you are going to contribute to the implant market in Nigeria, in your state, if you're in Port Harcourt, in Benin, in Lagos, your understanding of this is going to cause people to look at Africa and say, you know what, let's invest. Most up to now, I think there's been a very low investment in implant dentistry, because that is why you don't find it in the schools. Because in the United States, most of the implant companies are in the schools. They give implants free to students to practice, you know, so because they see the value of it. You know, I mean, in Africa, there's no implant company. All they want to do is to make money. You know, right now they're not thinking about education, but we at Educational Consortium, that is our goal. That is I take that role. It is my role to get into every school and to bring in the industry such that, you know, this comes to pass. Judge Zab has done his own. What are you going to do? What are you going to do about implants? What are you going to do about the knowledge? Are you going to train? So some people know implants and they keep it to themselves, you know, but we are going to share information so that we can improve our continent. This is not, and we are divided into various groups here. So in your group, try to learn something. Dr. Umuna, are you here? If Dr. Umuna is here, I just wanted to indicate. Dr. Umuna has attended the class. So we're going to go back. So that's a good question, Doctor. So the overall research has improved in terms of the way it is placed, in terms of the protocol. Endogenous implants, the protocol is, you know, implants should be placed, you know, gently, atraumatically, systematically, you know, and following a predictable sequence. And endogenous implants allow you to do that. Those transosseous implants, they actually place, it's very, very, I don't know if you have seen the orthopedic surgeon work. The thing is, it's terrible to see how sometimes bone is dealt with. They do that. With osseointegration, so far there is, the protocol is right in terms of making the osteotomy. You're gentle, you're following a sequence, there's irrigation, there's no overheating of the bone, you know. Dr. Omuna, I'm going to allow you to speak right here. I don't know why I'm calling you now, but I think I'll find out. Dr. Omuna, please, do you have any comments about how we can attract investors, implant companies into sub-Saharan Africa? Dr. Omana, yes, go ahead. Your mic is on, I can't hear you. If you have any comments, are there contraindications and indications of each type? Are possible for the person to have a hands-on? Oh, the hands-on is coming. The fact that you are in this course means you are going to get a hands-on in your city. So we are coming to Enugu, we are coming to Port Harcourt, we are coming to Benin, we're coming to Lagos, Ibadan, Abuja. We are likely to be in Maiduguri and Kano. Just praying for you know, just peace and just being able to travel to places safely. Yes, so that is going to happen. The hands-on activity is going to be part of it. Next week, we're going to have a recording by a colleague of mine where we're going to demonstrate what you're going to do. We're going to demonstrate it right here in this class. We're going to demonstrate it. Yes, you know, people begin to accept ceramic implants. It's not huge, but ceramic implants are here to stay. That is what Thomas Abraxan prophesied, and is here today. But it's still going on. So you have to go through studies. People have to try it and use it. But in terms of aesthetics, I mean, if you see the case I put forth earlier, it was a ceramic abutments. Ceramic abutments are there in terms of in the aesthetic zone. It's better to use something that's, you know, that is going to be translucent, so that patient doesn't feel that the implant is gray or something like that. The hands-on is here, and I'm going to learn more. So you have textbooks. I have put some textbooks there. This is no way exhaustive. What I've just shared is no way exhaustive. I've just gone through one article. There are a couple of articles on there that talk about the history. If you need more articles, if you want to participate in extra credit thing, put something together. Dr. Umuna, are you able to hear me? Are you able to speak? If you're not, no problem. I just wanted to get your view on how sub-Saharan Africa can attract industry into, especially Nigeria. You have about 3,000 dentists, and how do we make that happen? That is something, obviously, we can have this class deliberate on. Okay. Anyway, Dr. Timothy, are you there? Do we have any more questions? We have 6 minutes. I could take, if you want to speak, just raise your hand. I could give the microphone to you so that we can, I can, you know. Does anybody want to say anything? If you have any question, you want to type in the chat. If you have any comments, if not, we're going to get started with the. Yes, that is it. So there are other methods of improving osseointegration, which is sandblasting and plasma spraying, and the research is going on. Yes, Dr. Omana says that beginning with an education strategy is great, but we can also incorporate it in the entertainment industry scripts. Anodization, yes. I think so. Somebody, you know, yeah. I think, you know, because our people listen more, the entertainment industry is key in terms of information. I hope we can use that also in our electoral process where, you know, the songs that we sing can help us have stable governments. How about to visit Northern Nigeria? Northern Nigeria is part, not eastern part. I mean, Maiduguri, I'm scheduled to be in Maiduguri. You just get me a private plane and I'll be there. I know you guys have all it takes to get it, but Maiduguri for sure, because there are so many Maiduguri people from here, and definitely I made a commitment. Whenever we can get it close to between 40 and 50 people, I'm coming there. I'm coming to that place. So it makes sense, because I went to Warri the other time and there were just 6 people. It didn't make sense for me to travel down there. But Doctor, I'm going to hand it over to Dr. Tim to take over. Yes. Go ahead, Dr. Alade, your microphone is muted.
Thank you very much. Thank you very much, Dr. Uvoh. It's been very nice, always enlightening to listen to you. It's always great listening to you. Since we met the last time doing the training in Ibadan, I've really benefited a lot from this contact. So thank you very much. And again, thank you for having me on this course. It's quite, it's quite encouraging. Okay, so I'll go straight to my slide. I know that there are quite a number of us here, so I've created a slide in such a way that it appears to most of us. You know, we have students in this list, and we have people that are already versatile, that are already qualified. So I'll take it one step at a time, and I'll try to make it as basic and yet as informative as possible. So let's do this together. Okay, so as listed, I'm Timothy Aladelusi. I'm an oral surgeon, and we're just starting off in implant, and this is just some of the basics of implant that we're talking about today. And I'm putting this in from a surgeon's perspective. You soon realize, and as already been mentioned by Dr. Uvoh, that implant surgery, implant placement is multidisciplinary. So it's not just a single person that does everything. It's actually much better if it's more than one person that is doing it. So in Ibadan, we have a team, that is the implant team. I am on the surgical arm of that team. So they will be talking about what actually gave us implants, and that's osseointegration, and that's what I'll try to work with today. So this is Ibadan. For those of us that are in Nigeria, Ibadan is a very popular place coming to medical training in Nigeria. But for those of us that are joining us from other parts of Africa, Ibadan is in the southwestern part of Nigeria. It's actually just about 150 kilometers from Lagos, which is the economic capital of the country, but about 500 kilometers away from Abuja, which is now the capital city in Ibadan, in Nigeria. Ibadan hosts a lot of popular places, a lot of firsts, and I work at University of Ibadan. This is our entrance gate. University of Ibadan is the premier university over 70 years in Nigeria now, and it's also housed the first teaching hospital, which is University College Hospital, which is the same sister of the College of Medicine, which is primarily where I work in the Faculty of Dentistry, Department of Oral and Maxillofacial Surgery. So what is my goal for today, and what are we talking about in this class today? We're going to be looking at osseointegration. We do introduction, we do a bit of historical review. Thankfully, Dr. Onoriobe has helped with that, but I'll still go through some of the relevant ones. We're going to be going through a lot of definitions, because as we learn this trade, we need to learn from the basics, and those basics are going to be helpful when we go into the full scale of this trade. So I'll be throwing in definitions one after the other, and I hope I'm able to bring it clearly for everyone to understand what we're talking about. We'll say a few things about bone density, the biological concentrations, and factors influencing osseointegration. Then we'll wrap up. Okay, so as a part of introduction, we know that what is most important today when it comes to modern dentistry is the restoration of aesthetics. Aesthetics, contour, and function. These are the things that are of main concern to the patient when the patient is coming to see us. I'm saying that after we've been able to solve what might be the acute things like pain, but immediately the pain is over, a patient wants to look as unaffected as possible. So what we want to try and do is to ensure that the aesthetics is good, and we want to ensure that this is functional. What implant dentistry has offered us in dental practice is that unique opportunity to achieve this regardless of patient's dental state. That means regardless of what patient is, what the dental state of the patient in terms of edentulosness, we can actually give patients something that is aesthetically pleasing and functional. And this is this is a unique gift that we have when it comes to implant therapy. The primary function of an implant is actually to provide an abutment for a prosthetic device. So not to take chances, I'll just quickly go through the parts of implants. I'm sure quite a number of us in this class know this very well, but just to also bring it to perspective why there are different people working on implants. This is actually the goal, the most important structure that gives us implants, that give us the right to use implants every time. And that is what we usually describe as the fixture. This is actually the titanium implants, and recently the ceramics. This is what actually stays inside bone. These are the surgical stage, the stage that we call implant placement. And this is the titanium that actually gives us the opportunity to use an abutment, which is like a transition between the implants and the crown, which is the superstructure. There are instances where there is a connection between these, between the abutment and the implant itself. Many times they are screws. So these are the components, and what we're looking at today is this, which forms like the foundation of implant placement for the implantation of implant placement in our patients. So we need to understand how this will work. Very well so, and importantly so, Dr. Uvoh has actually said a lot about Dr. Per Ingvar Brennemark. It's the one that gifted us implants, and I'm going to say a little more about him in a short while, but we cannot start talking about implant without mentioning his name several times, because it's a singular ability to observe carefully that actually gave us these implants that we're all talking about today. Quite a number of people have worked on implant placement before, but none has given us the kind of facility that eventually gave to us. Okay, so what is osseointegration? Osseointegration is actually osteon, bone, and integrate. That means becoming part of bone, becoming a component in bone. That's what osteointegration means generally. And it's defined as a direct bone anchorage to an implant body, which can provide a foundation to support prosthesis. This, as said earlier, was developed by Dr. Per Ingvar Brennemark. But this has been modified several times. And the latest modification, which is usually acceptable, is the American Academy of Implant Dentistry modification, which defines integration as the contact established without interposition of non-bone tissue between normal remodeled bone and an implant, entailing a sustained transfer and distribution of load from the implant to and within the tissue. And this is highlighted in the images that we can see here. We can see that immediately if the implant is sunk, we'll see that there is bleeding. The implant fits snugly, which is what we describe as a primary stability that should be achieved if we want to go smoothly in the implant journey. And then there is neovascularization. We'll talk about that, the proliferative phase and maturation, when eventually we're able to have where there is no non-bone structure between the implant place and the bone itself. There are several cells that are involved with this, and I'm sure we remember our basic pathology, where we talk about the cells, the neutrophils, macrophages, which are responsible for the initial acute inflammatory state. And then we have the osteoblasts and the osteocytes coming in much later when we get to the maturation stage, from when we come to the proliferative and the maturation stage. Okay, so I'll start bringing in the definitions little by little, so that we don't get overwhelmed and drown in these definitions. But there are things that are important for us to understand as we talk about implant care. So osseointegration has been further broken down into adaptive osseointegration and biointegration. In adaptive osseointegration, the osseous tissue approximates the surface of implants without apparent soft tissue interface at light microscopy level. That means when we're talking about osseointegration, most of the things that we're talking about means that what we've been able to achieve when tested clinically and under light microscope, there is no soft tissue. But we know that when we go to a higher magnification of electron microscopy, and we are still able to confirm that there is no non-bone structure between the bone and the implant, then that has been described as biointegration. Professor Alkerson and Zaab defined it as a process whereby clinically asymptomatic rigid fixation of alloplastic material is achieved and maintained in bone during function. That means during functional loading, the implants behave like tooth. Nothing would disturb it in place. A lot of this history has already been mentioned by Dr. Uvoh. And yes, when we look at history of what has been done before, even before the Egyptians, we've seen mummies, we've seen excavations in China detailing about 1,000 years before the Egyptian discovery, showing how bamboos were inserted into tooth and then into the bone, and then the tooth is inserted just to replace a missing tooth. The Egyptians used shells, the Mayans used the Egyptians used shells and ivory, the Mayans used shells. Several things have been used, and even before Professor Ban Professor Branham time, a lot of people have used different types of bone, different type of metal, stainless steel metal, which has been used for transosseous. They've used iridium, they've used platinum. None was able to be inert enough to stay and remain functional fully in the oral cavity demonstrable for a demonstrable period of time. However, the work of Professor Mack, which was in itself not based on dental implantology in itself, I'll talk a little bit about that in a few minutes, actually revolutionized implant therapy in entirety, but gave us the specialty of dental implantology, which has been mentioned is a huge component of dentistry today. Okay, so what was Professor Mack working on? He was actually looking at bone fractures in tibia of rabbits, and what he was trying to look at is what it described as vital healing. So he wanted to actually see the process of healing in the bone of a fractured tibia, in the fractured tibia of the rabbits. But to achieve this, he had to insert a vital microscope. That's a microscope that is in situ. This microscope was actually housed in a titanium chamber. So this titanium chamber was inserted and it carried on with the study. So after the completion of the study, he needed to retrieve those microscopes. And he observed that the microscope, the chamber, that's the titanium chamber, which was housed in the microscope, has become fully fused to bone. And that's when he coined that word osseointegration. And that was the first time he showed that titanium will actually stay inside bone and will stay there without the bone complaining. That means there'll be no reaction from bone at all. However, it took him over a decade later to actually demonstrate this in dentistry, where he was able to put the first the first dental implants between 1962 and 1965, which was what which has continued to grow. And like Dr. Uvoh said, he lived into a good old age. He died in 2014. He was able to actually see that what he observed worked and worked very well. And it's become a very big component of healthcare in the world, not only in dentistry, but also in other applications in the limbs, in the hair, in a lot of processes. Also, integration has changed the narratives. Okay, so what are the mechanisms of osseointegration? A bit more about basic histology. After the surgical placement of an implant to an osseous location, the traumatized bone will go through the process of inflammation as we all know it. So this will become the inflammatory phase, the proliferative phase, and the masturbation phase. Immediately the implant is placed, we'll expect that there'll be some bleeding, and immediately that bleeding is done, the neutrophils are moved into that site. That arouse the inflammatory phase. The inflammatory phase will also bring in the macrophages, which are responsible for local cleanup. That is important because they're going to be responsible for taking off all the debris and other things that are not supposed to be at that site. After that, there's local hypoxia, release of cytokines. These cytokines are important, and we'll talk a little more about them when we get to each of those states in details. Neovascularization is the hallmark of proliferative phase, and that's the stage where there is formation of new vessels, which is going to be responsible for vascularization of the bone that are being formed. Masturbation phase will involve the formation of the bone itself in osteogenesis, and the formation of the bone will initially go into the woven bone formation, which is the immature bone, and this will essentially become mature to become the laminar bone, which will replace the woven bone, and then we'll have the bone fully reformed. This process takes about 8 weeks, and we expect that by 3 months, most of this will have been fully completed, usually in the mandible, and 6 months in the maxilla. This is dependent on the type of bone, on the characteristics of bone that is also receiving the implants, which we'll talk a little more about shortly. Okay, so a little bit more of information on inflammatory state. As we've said, this is essentially vascular. There are two phases of it, the vascular phase and inflammatory phase. In the vascular phase, the main event is the bleed and then the presence of platelets, which will initiate the clotting, and then the clotting will ensure that the implant surface and all the structures there we begin to have further aggregation and thrombosis. This thrombosis is bring into contact protein or foreign material causing blood coagulation at that stage. However, further down in the inflammatory phase, the bleeding will bring in some cells into that space. More cells will also be recruited to that site. The generalized inflammatory response will go on with the cells, the T cells, the B cells, the natural killer cells, the macrophages. These cells will be coming in to ensure that all the clot that's been formed are taken off. Some of those clot will actually form part of the scaffold that will be used for osteogenesis, but they will also be ensure that there are no foreign structure there, foreign body there, that will interfere with healing. So the T cells, the natural killer cell macrophages will be responsible for general cleanup in that area. Then the proliferative phase. The proliferative phase is we bring in the vascular ingrowth. There is neovascularization. Vessels will be formed that we transit from the bone surface to the surface of the implants. That vessels that have been formed will actually be responsible for the nourishment of the new bone that will be formed in that interface. An extracellular matrix is laid down by these cells, and eventually a fibrocartilaginous callus is formed that transforms to bone callus. And this is where the initial immature bone is formed, and it's the woven bone. Formation of the woven bone is the initial component of bone formation, and at the stage of woven bone formation, osteogenesis is already taking place. But this osteogenesis, the process concurrently continues, and there is ossification of the fibrocartilaginous callus, and this becomes the laminar bone, which is the consequence of which is the results of the maturation phase. So just to talk a little bit about osteogenesis, the osteogenesis will actually be, has been described in 1980 by Osborne and Newsley, to be in two phases. We have the contact osteogenesis and the distance osteogenesis. We remember that we've mentioned earlier that osteogenesis is the formation of bone. That means that osteocompetent cells, which are the osteoblasts, are beginning to lay down bone in a particular island. So there will be multiple islands of bone that are being laid down at the same time, because there will be multiple osteocompetent cells in that field. So there will be some of those that are in contact with the bone, and those in contact with the bone will be the constant osteogenesis, and those in contact on the implant surface itself is more of a distant osteogenesis. Now, what are the other concepts that are present? There is osteoinduction and osteoconduction. So I want to sandwich those two concepts between osteogenesis. Now, osteoinduction indicates that cells which are otherwise non-committal cells, those are the pluripotent cells or multipotent cells, are recruited to go into the line of osteocompetent cells. So in osteoinduction, there is release of bone morphogenic proteins and PP7, which are responsible for signaling the multipotent cells to become committed to the osteogenic line. Now, after the induction and they've been committed to the osteogenic line, osteogenesis now occurs because those cells that are now osteocompetent begin to lay down bone. That is osteogenesis. Like I've also mentioned earlier, osteogenesis is in multiple phases. So there's a need for those islands to coalesce. The coalition of the island means that the bones that are being formed are able to move smoothly across the surfaces on which they are being formed, and that is osteoconduction. Osteoconduction means that there is a scaffold. The scaffold of bone being formed are able to glide and continue to spread until they contact adjoining islands of bone, which are also being formed in several surfaces. So just a bit of detail on implant tissues or interface. Implants actually contact the tissue in 3 surfaces. What is most important to us today is the bone, but it's not only the bone that the implant contacts with. But looking at the bone, we want to be reminded that the implant bone interface, there is no connective tissue, there is no dead space. So the cells bind to each other and any other foreign bodies by a layer of extracellular macromolecules. And at this molecular level, the macromolecules are usually the arginine, glycine, aspartic acid, and integrins. The connective tissue interface has also been shown to be in the suprachiasmatic connective tissue. It's been said to be quite similar to junction epithelium, to the junctional surfaces that is seen in the natural tooth. And in the epithelium, the implant epithelial surface is considered as a biological seal, and this is what actually stops continuous ingrowth of epithelium into on the surface of the implant, and that is very important when we look at the success of implants following implant therapy. So comparing the implant itself and the natural bone, we'll see that periodontal ligaments are not present. Circular epithelium, junction epithelium, basal lamina are all said to be present. However, connected to you attachment is not present. Neither is there any need for circular probing or vascular supply at that surface, because exactly what is there is the bone. Unlike in non-natural tooth, we have periodontal ligaments which needs to be nourished. In implant, it's essentially bone that is next to the implants. So, to the core of today's topic, what are those factors that influence osseointegration? I've listed about 8 of them, the ones I consider to be most important according to literature. And these are things that we need to put our mind to when we are choosing or prescribing implants as a treatment option for a patient. Initially, when we're at the precision stage, and also when we are at the surgical stage, these are very important. Okay, so the first thing is the biomaterial. We know that titanium is the one that is most commonly used now, and we have the calcium phosphate ceramics, which are also being used. The zirconium is the most common in the market now. Like I've said before, other type of materials have been used for dental implants. They did not achieve osseointegration. So if the material is not inert, the material is not does not elicit any further inflammation in bone, then that material should not be used for implants, for dental implants. And just as has been said by Dr. Uvoh initially, if a material has not been shown, if an implant system has not been shown to be successful, it will not be allowed in the market. The next thing is about the surface. You know, we've said a few things about the surface when we're talking about sandblasting, anodization, other things have been done to ensure that the surface is osteoconductive. We know that this surface is an alloplastic surface actually, but it needs to be osteoconductive. That means that it should allow the continuous migration of osteocompetent cells along the surface, such that the osseointegration process is not disrupted. Some manufacturers have also said that they put on the surface of their implants osteoinductive components. This is still debatable, but yes, some actually says that they actually ensure that their implant have surfaces that have osteoinductive materials. Obviously, there have been several designs of implants, and most of them are basically spherical, cylindrical, with different form of formation of and structure and types. So it's important to choose the kind of implant that will fit snugly into the system that has been into the system. So if the well that's been created will not take that implant correctly, then it's important not to use that kind of implant, that kind of implant in the design. Surgical technique is key. And when we're talking about surgical technique, it has to be as atraumatic as possible. We want to ensure that we're using a sharp drill bit. Once the drill bit is becoming blunt, it needs to be changed. We need to use the drills in their process. So we use the pilot drill, and then we go 2530, 3540 until we get to the IS that we're going to for that system, depending on the choice of implant. We should not skip, because if you skip, then we're going to have a major disruption of the bone, which could influence osseointegration. Ultra low speed high torque drills are the ones that are prescribed for this procedure. Now, cooling is very important. Cooling is actually most important when we're using the pilot drill, because that's the point where we're using the heaviest, the highest speed. In other series, we're going to be using the low speed, and that is very important. We don't want to traumatize the bone. So I've brought out it as the most important component. When we bond the bone in itself becomes a foreign material, and that is going to be disruptive for the osteogenesis process. So it's been found experimentally that when the bone heating goes beyond 47 degrees for as short as 60 seconds, then it's possible that that bone will become necrotic, and when this occurs, the bone will not, the osteogenesis will become impacted, will become disrupted. There'll be an impact, a significant impact on osteogenesis. So we need to be sure that when we're going to use the pilot drill, especially, we are using it under very copious irrigation. We ensure that the drill bit is kept as cool as possible. Contamination is a no-no. And we know that many of the materials that we use for one of our implants comes in a kit, and that kit should not be opened and dropped on the tray. We must only remove it from that package and insert it without contaminating the surface, because any form of contamination, be it bacterial, chemical, any form of debris from the drill, could actually be harmful, and that will contaminate and impede the process of osseointegration. Primary stability is very important. When we insert the implant, if we've gone through the process correctly and we've chosen the right implant for the right well that's been created, the implant should sit snugly, and that primary stability will ensure that there is no disruption of the initial process of inflammation translating to the proliferative phase. We know that actually in the proliferative phase, the implant might actually become a bit more mobile, but it will not be disrupted again because the inflammatory cells would have been taken off. And at that phase, what is left is neovascularization, and the osteoinductive process are what will be going on at that stage. So there should be no disruption of healing due to mobility of the implant at the very initial stage. Bone quality is very important. So before we prescribe implants for a patient, we want to be sure that what is this bone that that we are going to be faced in this patient. Almost all bone have been used for osseointegration, although we know that the one that we use most commonly, the one that everybody is most comfortable with, is a type 1 bone. And this because it's compact bone is usually found in most of the mandible. Most of the anterior mandible is available. But when we get to the posterior maxilla and we're getting into a type 4 bone, then we need to tread more cautiously. And we also need to allow for more time for osseointegration to occur in that situation. This is also the mixed classification D1, D2, D3, D4, which are actually similar to what we have in the ZAC, in the leg on and ZAP classification. He actually added the tactile analog to the series. Epithelial downgrowth. Epithelial downgrowth is actually a negative, and we know that this means that there is continued downgrowth of the epithelium, that's oral epithelium, in the bone implant interface. So with this continuous downgrowth, the epithelium is going to eventually exteriorize the implants. So the exteriorization of implants is going to be the ultimate outcome of continuous epithelial downgrowth. A lot of work has been done on this, and it's now most of the new generation of devices ensure that there is no continuous growth of epithelium across the surface, so that the implants will not be exteriorized. Most times what we do is a two-stage, so we're completely covering the epithelium, allowing the epithelium to grow before we come back with an inlay abutment, which is what we now continue with. It's much safer for us using that technique in our practice. Loading system is also important. Loading scheme as we go on in this course, we'll learn more about loading, delayed loading, early loading, immediate loading. Delayed loading means that we're going to wait for the period of healing. That's 3 months in the mandible, 6 months in the maxilla before we attempt putting the superstructure in this patient. Or we are going to wait for less than that time to do an early loading in selected cases. And for some selected system, immediate loading is actually possible. And I'm sure we'll also learn about that in this course. But because of the type of practice that we have, which is a public practice in the University College Hospital Ibadan, we do a delayed loading. And this has been quite useful in our environment. So how are we sure that osseointegration has occurred? For us to be sure and be surely sure, most of the things that we do are the invasive methods that has been prescribed by invasive method. But we know that these invasive methods are not useful in everyday clinical practice. We cannot do histological section, we cannot do transfer electron microscopy. This will be done before the implant is allowed into the market. So what we do are mostly non-invasive clinical tests. So we do non-invasive, like a percussion test. We expect a good resonance. If the resonance is good, then we'll say yes, that's a good osseointegration should have occurred. But if it's dull, that means there's a fibrous interface, and that means that implant is looking failed. Radiography is important. We want to look at if there's any bone loss, if there's any radiolucency around the implant, that tells that there's something that is not right. Reverse talk test, resonance frequency analysis are all parts of things that we can use to evaluate the osseointegration. Now, this is the hallmark of implant placement, and this is an evaluation of osseointegration by Professor Alcotstein. It's been published since 1986. Not much has changed since then. The individual unattached implant should be immobile clinically. That means when clinical reasonable effort is placed on it, there should not be any evidence of mobility. Radiograph should show that there is no evidence of radiolucency around the tooth. There should not be any loss of bone around the fixtures of more than 1 mm in the first year of implant loading. Obviously, there should be no symptoms. There should be no sign, no pain, no infection, no neuropathy, no paresthesia. The canals should be saved. The sinus should be saved. That will be an effective implant placed and that good osseointegration. The success rate should be at least 85% in 5 years and 80% in 10 years. So if we're not achieving this, then we need to refine our process and we need to do it better. So in conclusion, osseointegration is one of the most important aspects of implant placement. This is actually what is going to form the foundation for the implant, and the success of osseointegration is mandatory if the implant is going to achieve the functionality which is expected of implant. So it is necessary to be aware of the mechanism of osseointegration in order to direct research and to enhance success. These are some of my selected references. So we'll place an implant. We allow for primary healing that's when we do a 2-stage. Then we come back and put an abutment, the healing abutment, and then the final abutment, and then we have the superstructure placed in. This process involves the surgeon and restorative dentist, the periodontologist, the prosthodontist. Everybody is involved in this process, and all of us should work together to ensure that this is the kind of care that we give our patients whenever they need this kind of service. Thank you very much. I would like to take questions and comments at this time. Thank you.
All right, thank you so much, Dr. Aladelusi. That was this lecture continues to be a it's a loaded lecture. You need to go back to the video and slide by slide. There's going to be a post. Dr. Aladelusi, do you have any questions for them to access the material? Do you put together any post-test questions?
Yes, I did send it to you.
All right, okay, no problem. Can you make it 10? I think 6 will not do justice. Even 10.
6 will not do justice.
Even 10 is not enough. But I think this will provoke. I mean, each slide is loaded. I mean, and some of us are getting this lecture at no cost. That's what I call it. This is a gift. What Dr. Aladelusi has put together is a gift to Africa. That's what I call it. Because if you don't know this, you shouldn't be doing implants. You should understand what is happening at the molecular level so that you can understand when things go wrong and how to mitigate any issues that you have with placement of implants. We're going to have a lecture on complications next. Not today, but I'm going to put that lecture together. You need to know what to do when something goes wrong. Dr. Aladelusi, please don't go away. No, we are not sharing PowerPoint.
I'm still here.
Are you giving away PowerPoint? I don't think we should do that. They should go back to the video.
Okay.
If you want the PowerPoints, I'm sure we can make it available at some point. But for the essence, this is a class everybody has to attend, and the material is available. So you have the recording. You can pause it. You can make your own screenshots. But I think this is intellectual property. You know, I know it's available on there. All the textbooks are there. What he has said is not something he made by himself. He gave references where he got them from. So and that he has made available to us. I think that's sufficient for this class, you know, because, you know, people are funny. You know, that's just the truth. You don't really know. It is just what it is from everywhere, from around the world, from China to Russia to Ukraine. You know, there's all kinds of funny things going on. But obviously, you have these recordings available, so you can. So, any questions? Let me see. Did anybody put any question there?
I've not seen. Okay, maybe some questions are coming in.
Arnold,
okay, someone said, is osseointegration means 100% of implant contact around the entire circumference of the implant? Yes, it's 100%. Even at electronic implants, the electronic microscopy level, it should be completely bone to implant, complete. That is what is described as being a bowel integration, or some interfacial soft tissue.
Can you go back to that slide by Dr. Abraxan about the criteria?
Okay, I now that question is, I'm not sure what Dr. Arnold is saying here. He said, or some interfacial soft tissue acceptable? No, there shouldn't be any soft tissue between the bone and the implants, if that is what the question is.
Right.
No. There should be no implant. There should be no soft tissue between the implants and the bone at all. None at all. That is actually osseointegration. If you remember the definition of osseointegration, it means that there is no non-bone tissue, no non-bone structure between the bone and the implants. So it's for it to qualify as osseointegration, that has to occur. And if that is not what we have, then the implant is not going to be functional. It will not be able to carry the prosthesis that is required to provide the function and aesthetics that the patient desire. So that's the situation.
Okay, like use your slide number 3. You talk about, I mean, obviously once it's supposed to be 100%, but over time you do have some bone loss. and he was saying in number 3 here that the vertical bone loss should be less than 0.2 millimeter per year after the first year of loading the implant. So, obviously over time, you might have some space in there in terms of the bone loss, but, like you said, like you just said, 100% is the way to go. All right. Arnold said, okay, he gets it.
Yeah. So after 5 years, 85% success should still be there to qualify to continuity straight. That means if in 5 years many of them are down, then it's not. We need to refine the process. So the process has to be optimized to ensure that it keeps working.
There's a question by Dr. Atat. Is it from this lecture, primary stability should be achieved in 6 weeks? He said, I used to know it is 3 to 4 weeks.
No, primary stability is achieved immediately the implant is placed. That's the primary stability.
Right there.
That's primary stability. Once we place it, you should know that this implant is not dancing in that well that it's been sunk into. Otherwise, it's not going to work. It might work. I'm sure Dr. Uvoh would have had experience with this. There might be need for bone augmentation. There might be need for post-substitute application. But primary stability should be achieved as much as possible. Okay. That will interfere with subsequent healing if it's not great at the time the implant is positioned.
Okay. Next week, I'm going to go over the first EC 102 lecture that we have so that we can just take it from there, take it from where we are right now. So it's right now, at least we have a good understanding of osseointegration. There is materials on there on the site, on the classroom for us to just kind of catch up with our knowledge. There's things that are due. Let's see, does the drill take the same shape? Just going to look at, there's about 4 questions there, Dr. Aladelusi.
Yes, I've seen it. I'm looking at them. Does the drill take the same shape of the implant, more like a screwing method? I will not be able to tell exactly, but looking at the implant, you know that the implant has the height and the width. So the system that we use, which I should not mention every time, it shows that the size, that's the depth and the width of the implant that is supplied fits snugly into that space that is created by the drill. So that's the kind of situation that we have when we use that system. Now, I've seen some other system where the shape is not all regular, and I'm not sure how the how the drill will relate to such.
Just so most of the drills are cylindrical, and right now you have tapered implants. So there's a drill in the protocol. There's a way of making a profile where you where the coronal portion of the osteotomy is tapered a little bit, such that after you use the cylindrical drill, that coronal portion is tapered using the profile drill to make sure that it sits properly. So, so it all depends on the system you're using and the protocol that they have put forth. Yeah.
Okay. So someone said, sir, following immediate loading of the implant, is it only for us to get osseointegration? Yes. And Dr. Uvoh has a lot of experience in that, and I'm sure we'll bring it up at some point. Yeah.
We're having we don't have a Strawman rep for part of the United States is going to come up and tell us about their new product. There's a product called the BLX. The BLX is a new Strawman product that is used for most immediate cases. So he's going to talk about that product that they have for immediate. So they've optimized it, especially with the SLA, and that is what is being used. If you go to YouTube, you can actually find videos of that. I will talk about it in our next class.
Okay. Thank you, sir. Someone said, can someone ask a question, Dr. Ituno? Can someone with well-controlled DM have an implant? Yes, it's controlled. Yes, the person could actually have an implant. It's not a contraindication. It's something that will be done cautiously, but yes, it could be done. Thank you, sir. Please, can you briefly explain this slide of epithelial downgrowth? I think I did, but obviously I can say that again. We know that there's oral epithelium here, and the oral epithelium will actually continue to grow and interfere with the bone. And you can imagine this oral epithelium continuous downgrowth is going to exteriorize this implant. That means there's going to be an oral epithelial between this implant and the bone. And with that epithelial layer, yes, this implant will need to go because it will not work. So that's why I try to explain there. Thank you, sir. Please what will cause increased temperature even when you are cooling with saline? Okay, like I did say, the initial time when we use the fast speed, the highest speed is at the pilot drill level, and that's the drill where that's the stage where cooling is most important. So if we do that correctly, the bigger drills are actually at low speed. And in that case, we don't even need to irrigate again at that point. So there should not be any reason for a need for cooling at that stage. I don't know if Dr. Uvoh would like to make a comment on that.
Yeah, so in terms of increasing the temperature, because if you're it depends on if the motion you're making is the irrigant going into the osteotomy as you're doing. So if you're drilling and even if you are having irrigation on, the fact that you're not doing a pumping action. So your pumping action allows the irrigants to go in while you are drilling. So it goes in and out, in and out. But if you just go in as if irrigation is pouring, but it's not going into it, obviously you can have an increase in temperature. So it depends on your sequence. So for those who had the hands on, we said it was in and out. So that when you go out, at least there's blood coming from the inside and the irrigant going from the outside. So, and some of them have improved irrigation techniques, but I think that's the way that you can have it. But initially, like you said, if it's that one is about 2,000. If you're going at 2,000 and you're not getting any irrigation from the onset, that is the beginning of trouble. I know you mentioned 47 degrees. There was a slide where you did mention.
Yes.
Okay.
Yes. Yeah.
We do have, so let's try to keep the question in the Q&A section, but I'm going to go to
Yes, I did. That is irredeemable.
Yes.
The questions are coming. Is there instruction given to patient to retain primary stability? No, it does not depend on the patient. It's depending on your technique, right? It's not dependent on the patient.
I mean, primary stability also depends on...
Dr. Anodekin, as far as also depends on...
No, I was talking about the bone density that the patient brings.
Bone density, yes, type of the bone that it is bringing, yes, that's true. But it's not dependent on the patient. It's not the patient that will be responsible for that. It's the technique and what we're working with. As far as osseointegration is concerned, I'm interested to know the concept of implant rigid fixation and the crude tests. Dr. Uvoh, I'm not clear about that.
Okay, we're going to treat that in a future class in terms of when we talk about the protocol. So we're going to discuss the rigid fixation and the crude test in the other time. Yeah. Dr. Arnold, what background do you have? The questions you ask shows that you've had some training in this. Okay, but good to have you here. Yeah.
You may mention that the most preferred bone type is one. Does that mean type 4 will have little chance of success? Success is more guided, but yes, I'll still be good success. If the protocol is properly followed, it will still work. Why is any shorter in mandible than maxilla, the type of bone? The bone in the maxilla. I want to go up and see where the questions are coming from. Will functional stress not affect in primary stability in immediate loading? Yes, I said Dr. Uvoh will still talk about that at some point, but yes, the functional stress will be reduced. That means that we're going to reduce the kind of, we're going to take it off occlusion as much as possible. But that will also be meant to be dealt with in future classes.
There's a question here. There's a question here about
we put a cover on it, close, and then when we open. Okay, I'm just going level by level. I think that's dependent on the protocol. It's dependent on the system, actually.
Yes. Yeah, you're right. That's exactly correct.
Why is healing shorter in mandible than maxillary? I think I've mentioned that. Please, how are there many other type of palm material for implant apart from the 3 being mentioned? Which 3? Please, also, are there any other type of palm material for dental implants? I'm not sure. I think what we've talked about essential titanium implants and the ceramics, which are essentially the zirconium that is in the market now. But I don't know the 3rd one. I don't know, Dr. Uvoh, if you understand that question. Are there any other type of palm material for dental implants?
Apart from ceramics and titanium, is that?
And titanium. I don't know what the 3rd one is, and if there are others apart from those 2.
Yeah, I mean, as of today, titanium is what is used for osseointegrating things that we needed to save. So so what we're going to do at this point, Dr. Atat, can you please copy all the questions? I'm going to save them on the Zoom thing so I can reach out to them. But if your question was not answered, we can take your questions. You can email your questions to training@hhands.org, and we will try to give you.
Okay, so I think we've attended to most of the questions.
Okay, thank you.
Yes, I think the maximum drill dependent type of bone, I think we attended to that too. So I think we've dealt with most of them.
Thank you so much.
I think other question keeps coming, but yes,
we can. So what we're going to do? Yes, I'm going to put in the chat section if you have more questions.
Implant is bone to implant. No, okay, this question, let's just look at this Dr. Ayama's question. Is he or she, I'm not sure, please, pardon me, said if the union between the so it said if the union between the implant is bone to implant, which excludes periodontal ligament, will there be a failure of the implant if it's used as an anchor tooth for a bridge? No. It's all on 4, and it's 4 implants will carry everything. So the periodontal ligament does not change. The absence of periodontal ligament does not change the functionality of the implants, if I understand the question.
Yeah, I mean,
is that true, sir?
It's osseointegration. Osseointegration
is also integrated,
bone and metal.
You don't need the periodontal ligament.
Yeah. If it is there, if it is stable.
So the metal is essentially bone. Yes, it doesn't need an. Someone is asking now we have access to the lectures and videos. Yes, I'm sure we'll make time for
it's
that.
Going to be, this video is going to be, I'm going to put the raw file from Zoom straight into your Telegram group, and it's going to be available on the site, on the classroom. Sorry, this is available to only those in this class. Sorry, please, let's keep it. This one is for those in the class. So thank you. Let's keep it that way. After this class, after a couple of times, then we'll make it available on YouTube. But for right now, the Zoom link is going to be available, and it's for only those in the class. Please do not share this outside. It's not about, because we just want to be able to say, okay, we account for those who are getting this information so that we can. But the video for sure is going to be, the link is going to be available on the Google Classroom and in our Telegram group. So just watch out for it later today. Thank you so much, Dr. Aladelusi. That was a fantastic lecture you've had there.
Thank you very much, sir. And thanks for having me.
No problem. All right, I'm going to do some housekeeping. We have 8 minutes to go. This was a beautiful one, and every week we're going to have lectures coming in. This week we have a lecture that is not in this class, is on rotary endodontics. I'm sure you've seen it. I didn't post it in the classroom. It has nothing to do with this class, but it's just for this one, we have about room to take 1,000 people. So when it gets to 1,000, you'll be able to join that endo class. People are already, it's already been, and it's a free class. But if you want CME credit, or if you want any certificate of some sort, you have to give a little token for it. But it is a free lecture. But if you want anything about it, if you want to, add it to whatever you're getting, then you have to pay something for that. But it is free. I mentioned that because a lot of people have been asking questions, but it's just I had the opportunity. I met this person somewhere in the elevator. I'm like, can you give this lecture? And she said yes. Strawman is coming next week to give us a lecture, in 2 weeks' time, I think, to give us a lecture on their Strawman protocol and what they have right now. And that will be a very good lecture. We also have Dr. Song coming to give us a lecture on let me pull it up on surgical anatomy. Surgical anatomy. That lecture is coming up soon. Let me see. Let's see here. So it promises to be, this is going to be, you are going to be really, really enriched in this class. It's a blessing to have people willing to contribute to what we've decided to do here. And it's going to be good. We also have a lecture coming up soon on treatment planning. I gave this lecture. I did speak recently at University of Michigan, and someone said, you know what, I want to be a part of it. She's going to give a lecture on taking a medical and dental history. She's a psychologist that is attached to University of Michigan, and she helps us with fear, dental phobia, many other issues. She'll be here. We're also having surgical anatomy for implant placement with Dr. Song. That is coming up on the 26th. On the 26th is loaded already. We also have a friend of mine, Dr. Luke. Dr. Luke is a general dentist that has placed over 150 implants. I want to bring him here so you can see that it is possible. He doesn't probably go through all this protocol we're talking about, but it is possible, and he's going to talk about the system that he uses, and you can have questions to ask him. And the Strawman, so we have a couple of people already lined up, about 10 speakers before, by July 30th, 31st, all this is going to be over. So let's take advantage, do the assignments. I'm not going to put anything due now, so please help your class, your group mates to catch up. I don't want to introduce anything due until what we have done. So if one person has not done this, you are delaying us from moving forward. I'm going to put some material on there. We're going to talk about treatment planning next time. I'm going to go over the possibilities of dental implant, what you can do with implants, and I'm going to go about the protocol. I'm going to go. That's going to be an important lecture next Sunday. Is going to be. I'm going to talk about that and see who else is scheduled to come in. It promises to be so classwork. I'm going to go through the classwork thing again. So Enoch, are you there? Dr. Ijibani, are you there? Ijibani. If you are there, I want somebody to share their screen, because most people are finding it difficult just submitting. Right now, we have only one person who has turned in the fact that you are present. So we need to figure out how you can do it on your end, because my end is a little different, so you can see how to do it. And some of the assignments, I need you to turn it in. Some people are having difficulties. I want someone who is there. Enoch Ijbani, you are the first person to turn yours in today. Sorry, I'm just going to pull this up and show you who has already. Yeah, Enoch, you did turn in something here. So just to see how to turn it in from your end. Let me see. Is Enoch there? Okay, so I said after the class. Okay, good. But I want somebody to show me from your end so that others can see. What we're going to do next time. I can work with somebody offline. Okay, Enoch is here. Enoch, I'm going to allow you, Doctor. Okay, I'm going to allow you. Are you able to share? Are you using a computer, Dr. Enoch? Are you using a computer or you're using an iPad? Okay. Are you able to show us? Are you able to share your screen? Does it allow you to do that? Enoch, can you please raise your hand up so that I can see you? Can you speak now?
Okay, thank you. Yes.
All right. So I want you to share your screen and just go through turning it in. We should be able to do that like right after the class so that I don't have to go back and forth. So show me what you see. I want to see and how to attach a document. Some people are having difficulty, so I need somebody to just, from the class participants. I'm going to stop sharing my screen right now. So Enoch, let me know if you are able to share your screen. Yes. So if you're Chidima, your question was, does cigarette smoking and post-implant procedures affect you? I don't know if there's a class assignment that talks about this by Dr. Soni Prasad. That is what we should, okay, yeah, go ahead. So go ahead and get into the classroom, Dr. Enoch can show us. So he's logging into the classroom right now, which is what everybody's going to see, right? That is perfect. So you go into the classroom. Okay, so that's him. So how do you turn it in? You see just right there, show your work. So you put, if there's no attachment or whatever it is, you just say, you just turn it in. For this one, you don't have to, you can even write. It says, say, show your work. So can you go back how you navigated to that? Can you go back again? Just go back to the class again. Yeah, good. So you go to June 12th, click on it, and your work. So this is where you turn it in. So everybody should be able to do that. And just turn the fact that you were present. And go back one more time, Dr. Enoch. Enoch, we have to work together. We have to work together. I want to go to pre-class assignment. You see, many people have not done this assignment yet. There are 3 videos, one by Dr. Matt Gali, another by Dr. Soni Prasad, and a video by Dr. Peluji Balis. You should have a summary and attach it. So you go there, you can attach it. So don't send it to me via email. I won't be able to check it. You need to go in here and send it as an attachment. You should make the file PDF or Word and you attach it. One more time, just go back one more. Let's go to, there's a quiz that is due. You click on it, you go to the quiz number 1. So this week we have our hands full. If you want me to chill a little bit on the 19th, so I don't add another thing, but but it's just unfair for those. How you turn on the attendance? Okay, yeah, just go back. So it's like, yeah. If you go to the mandatory webinars, somebody's asking a question, yeah. So you go to, that is it. The topic is mandatory webinars. You click on the dates today, June 12th, and you just your work. So it's like, as though this is where you turn it in. So you put an attachment. For this one, there's no attachment. If you want to attach something, you can put your screenshot of yourself, okay, in the class. So if you want to attach something, you can put a screenshot of the fact that you were here and just turn it in. Turn something in that shows that you were here right now. So if you do that way, I don't have to, I think that would be better. Just take a screenshot of what you saw, any screenshot you got of the classroom, and we can turn it in and you'll be good. So I can just grade that portion. Let's go back. Thank you so much, Dr. Enoch. This is, I think we're going to run this class together. So there's a pre-class assignment. I don't know what else, the Meet Me. Meet Me, many people have not done Meet Me, the same thing. If you click on the Meet Me from your end, so you're supposed to, under your work, you're supposed to send a file and it should just fall in a document, so you initially find it difficult, but this is it. You put your name, country, just like that, insert a photograph inside the Word file and send it as an attachment. And so that's how you do the Meet Me. So let's try. The Meet Me is really important so I can know who's in the class and who's not. There's some people I need to remove from the class, really, because if you're not a dentist or a dental student, you shouldn't be here. So I need you to remove yourself so that, you know, there's a class for technologists. I'm not trying to teach a technologist how to place implants. This is for dental students and dentists. I really have to make it clear. There's no room for therapists. No offense to anyone, but this class is for dentists. And somehow we cannot share links. Google Classroom, the package we have right now does not give me, you know, in terms of security or anybody can join. You know, I don't want you to give the link to anyone. Just for our own safety. Your emails and stuff are on here. You don't want anybody who is not a dentist or some stranger coming into the classroom. So let's keep it. I'm going to move to a different platform very soon. But right now, I'm just keeping with the resources that we have. Getting a specific classroom adds some cost to it, and obviously we're going to get there. But thank you so much, Dr. Ijabani. That was truly okay. I'm going to end our meeting today. Thank you so much. I'm going to end our meeting today. Thank you guys for coming in. If you have any questions, any concerns, you know how to reach me through email. Some people have my number. Just send me a quick email, send me a reply on the Google Classroom to be easy. There are about 160 people in this class, so I cannot be taking messages. So if you put it inside the classroom, I check the classroom ever so often. Next week, we're going to have some good time. So let's get the pre-class assignment done. Dr. Umuna, your summary is always fantastic. I have a couple summaries. Dr. Monina, I think I can't remember the last name now, but very good summary. It kind of helps you with all this. If you have done the pre-class assignment, then the rest of it just builds on. Next week, I'm going to go over my first lecture that I give to just give us the possibility. So you can, some of the questions we've asked today are answered by that lecture. So that's why I said we should just hold on. But anyway, looking forward to meeting you. And those of you, if you want to get, I think it is key that you start planning to get your kit. You can choose any system you like. There's Uvoh. I'm trying to talk to the folks that sell it to try and reduce the price. Reduce the price, people can afford it. You know, there's no point putting, you know, I'm trying to talk to them. And I hope they listen. If not, we're going to bring in a product that everybody can afford. You know, for this class, if you're a member of this class, you have access to a product that you can afford. That is what's going to happen because there's no more patent about implants. It is the same thing. So far, it's FDA approved. It can be used anywhere in the world. And we're going to bring a product that people in this class can afford. So they have to listen to us. Well, we have Africa. They should reduce it for Africa, you know, they should, and we're going to make sure they do. We're going to make sure the worst case scenario, we're going to bring our own implants that we can sell the implant for 20,000 naira. We can't do that. It's just a matter of volume. If we have enough volume, we can reduce the price of an implant to 20,000 naira. That is what we are going to do in this class. You know, so if they are listening, they have to listen to us. They have to bring the price down. I mean, why should an implant cost $100? Why? I don't understand why. Obviously, people are trying to make money. Obviously, it's new. But if more people are trained, then you tell me if 20,000 naira for an implant is okay. Then we'll make sure that product is available to all of us so that we can place it. If you have patients already, I have a couple of people who have patients, so you just have to put the case together so that we can use these implants. I already have the implants with me. They are MSDI implants all the way from Israel, and they are willing to support this class. So they're going to give us at a ridiculous amount that you can afford. So if you want it, you just need to get a kit and we can get the implants across to you. But anyway, let's talk more during the week and get ready. I'm going to show, let me show you. Maybe next time we come, we could talk about it. Well, you guys have a wonderful Sunday. Yes, a morning now. Organete Gloria. I saw your submission. Very, very good submission. Very good submission you put out there. Thank you. Thank you those from Enugu, from my boy, from Maiduguri, from Kano, from Port Harcourt, Lagos, Abuja, my Ibadan people. You know, Ibadan is likely to be, you know, a place where we're going to settle down and have our first implant center. We're going to have an implant center in Nigeria where you can come there and it's going to be a room filled with about, you know, various tables that are already set up for you to place and practice and do everything you need to do. That's coming up. That's coming up. And in October, we're going to have a conference. So let's put that in our agenda. I'll work with the NDA to make sure that this comes to pass. Anyway, until we'll see again, keep your questions coming, email them to training@hhands.org, and we'll have a wonderful, wonderful Sunday evening.